Good evening, sir and fellow students. My name is Donald Primus, and this video is being done for epidemiology class. Today's topic, the natural history of a disease, and today I chose to speak on botulism. Let's begin. Introduction, defining the natural history of a disease. In epidemiology, the natural history of a disease refers to the timeline and sequence of events that occur in a human host from its initial exposure to a pathogen or causative agent through to the final outcome. In the absence of any intervention, it is the untreated story of a disease, providing a baseline against which the effectiveness of preventative and therapeutic measures can be judged. This process is typically visualized as a continuum, segmented into two primary phases, the preclinical phase and the clinical phase. Stage 1, exposure, the point at which a susceptible host encounters the causative agent. Stage 2, preclinical phase. This phase begins after exposure and the initiation of the disease process within the host. It is subdivided into the latent period, the time between exposure and the onset of infection for diseases that are non-communicable. This concept is less relevant and the focus shifts to the incubation period. The time between exposure and the first appearance of the sign or symptoms. This is critical epidemiological measures for investigating outbreaks. Stage 3, the clinical phase. This phase begins with the manifestation of discernible symptoms and signs. It is often marked as a period of nonspecific symptoms, prodrome, before the appearance of classic disease-specific symptoms. Stage 4, the outcome, the final stage of the disease process, which may include complete recovery with residual disability, or death. Understanding this progression allows public health professionals to identify and target points of intervention, such as primary prevention, meaning preventing exposure, secondary prevention, early detection and treatment during the preclinical phase, and tertiary prevention, managing disease to improve outcomes and reduce disability. We will then talk about the natural history of botulism. Botulism is an acute, flaccid, paralytic illness caused by the neurotoxins produced by an anaerobic, spore-forming bacterium, Clostridium botulism. Applying the natural history of disease provides a clear and actionable framework for its management. Stage 1. Exposure occurs through one of several primary routes. Foodborne, meaning ingestion of the preformed toxin in properly processed or stored foods. Examples can be canned foods, fermented seafood, or potatoes baked in a foil. Infants can also get botulism, and ingestion of C. botulism spores, which then colonizes the infant's gut and produces toxins that are live. Wombs. Contamination of a womb with spores which germinate and produce toxins in an anaerobic environment of the necrotic tissue, or other, the inhalation or iatrogenic inhalation, example bioterrorism scenario, or the iatrogenic from cosmetic or therapeutic injection of botulism toxins. Stage 2, the preclinical phase. Upon entry, the botulism toxin is absorbed into the bloodstream, food-borne as an example, or produced locally, infant or womb. The toxins travel to the perineal chologenic nerve terminal, where it binds irreversible and blocks the release of the neurotransmitter acetylcholine. The time from exposure as the first neurological symptom of the incubational period. This period is highly variable. Foodborne botulism typically 12 to 36 hours but can range from 2 hours to 8 days. The shorter the incubation period, the more severe the disease is generally expected to be, as it indicates a higher toxin dose. Infant botulism, more difficult to pinpoint, but generally 3 to 30 days after spore ingestion. Womb botulism, typically 4 to 14 days. During this entire incubation period, the patient is asymptomatic, but the irreversible neurological damage is progressing. Stage 3, the clinical phase of botulism is characterized as an acute, descending, symmetrical, flaccid paralysis. Predome, nonspecific symptoms. In foodborne botulism, some patients may experience mild nausea, vomiting, and abdominal cramps. However, these are often absent or overlooked. Classic disease-specific symptoms are neurologically and bilaterally affecting both sides of the body, beginning from the cranial nerve paralysis and descending. Key symptoms include, in early detection, double vision, blurred vision, drooping eyelids, dry mouth, difficulty swallowing, and slurred speech. Progressive, descending weakness from the limbs and torso. The paralysis is flaccid and with preserved sensation and a typically clear sensorium. Severe progressions of respiratory failure due to paralysis of the diaphragm and the accessory muscles of the respiration. This is the primary cause of death. The outcome of botulism, stage 4, is directly tied to the speed of diagnosis and the intensity of supportive care. With prompt administration of botulism and antitoxins which neutralize circulating toxins but cannot resolve existing nerve damage, and most critically prolonged intense respiratory support, mechanical ventilation, patients can survive. Recovery occurs through the sprouting of new nerve terminals, a process that can take weeks to many months. Recovery with disability. Patients may experience prolonged fatigue, shortness of breath, and weakness for years. Death. Without adequate supportive care, particularly mechanical ventilation, the case fatality rate can be higher than 50%. In modern healthcare systems with advanced intensive care, the mortality rate for foodborne botulism is typically 5 to 10%. Public health implications. The natural history of botulism starkly illustrates the critical importance of primary and secondary prevention. The key points of intervention is before the clinical phase, as toxin actions are irreversible once bound. Primary prevention focuses on preventing exposure. This includes public education on safe home canned practices, regulation of commercial food production, and discouraging the feeding of honey, a known source of spores, to infants under 1 year of age. Secondary prevention. This is the most critical medical intervention. A high index of clinical suspicion leading to rapid diagnosis and immediate administration of antitoxins is essential. The antitoxin is only effective while the toxin remains unbound in the circulation, making early intervention during the transition from the preclinical to the clinical phase, which is paramount. Early cases identification also triggers public health investigation to identify the contaminated food source and prevent further cases. Tertiary prevention involves comprehensive intensive care, particularly mechanical ventilation, to prevent death from respiratory failure, and rehabilitation services to manage long-term weakness. So to conclude, the natural history of botulism teaches us the best solution for prevention is stopping exposure from safe food handling is the most effective way to fight disease. Time is crucial. The nerve damage from the toxins is swift and permanent, creating a narrow window for treatment. And early recognition saves lives. Quickly diagnosing symptoms and providing intensive care, such as ventilators, is the only way to preventing a fatal outcome. This is the end of my presentation. Thank you. Good evening.